So good morning, everyone, and thank you, Vasudha, the organizers, and Nihar for the kind introduction. A very apt and interesting topic, and it gives also me an opportunity to review this topic recently. Just one sec. I'm just going to. Yeah, so we all know that there has been tremendous progress been made in pediatric ALL, a disease which was probably less than 10% survival to more than 90% recently. So it's a success story of pediatric oncology, so to say. And multiple groups have shown this. This is the data from the St. Jude's. We are very aware of this very famous graph, and it has shown over the period of time in the last 4 to 5 decades. The survival curves have been pushed to more than 85-90%, and the similar kind of experience from the children oncology group as well, in their successive multi-center collaborative studies. We also know that pediatric ALL is a genetic condition, and we can now demonstrate in each and every patient probably a genetic abnormality. So it can be every disease, every ALL patient can be substratified genetically now. But what has been very, very shocking is that these genetic abnormalities really determine the outcome of these patients. And on one of the spectrum, we have got the good ones, where the outcomes are probably more than 90%, and then we still have a high risk genetic group, which doesn't do really well. Now, what determines the outcome of a pediatric ALL? The end result, of course, has to be treatment response, but then that will be determined the type of therapy they're getting, the type of leukemia cells you're dealing with, and of course the host microenvironment, and probably drug resistance has to part of play. And the end result of all of this now would be treatment response. And we also have got now tremendous amount of data and information on how the treatment response measured as minimal residual disease is going to determine how the patients are going to behave in the long run. And the ones which are which become MRD negative quickly will definitely do better, and as compared to the ones who remain MRD positive are going to be the high risk ones, and the ones which are going to have a relapse and a disease failure. Now, we also know that the relapsed ALL in childhood, the upfront treatments have really upfront response rates and cure rates have really improved tremendously, but relapsed ALL still remains a little concern, and because of the sheer numbers of the cases of pediatric ALL, relapsed ALL is formed the fourth most common cause of childhood cancer. And it has been seen that, depending on whether the response is early or even late bone marrow responses, the outcomes have been very, very poor. And this has been demonstrated in multiple studies, the response rates being in the range of, about 10 to almost 50-60%, depending on what time you relapsed and what kind of era the patients belong to and what type of treatment was given. And same has been the experience with the second or subsequent relapses. And this is basically, if you see, these are lab response rates. These are not even, the long-term survival rates. So the response rates in the relapse pediatric ALL and refractory pediatric ALL are still a challenge, are still optimal. So now, based on what we just kind of discussed in the introduction, that patient with high risk MRD, patient with bad genetic prognostic markers, patients who have relapsed or refractory disease form a high risk category, and the outcomes of chemotherapy in those patients are suboptimal. There have been a lot of advances being made in the last few last couple of decades. The way we deal with adolescent and young adults, Ph positive ALLs with the introduction of TKIs. How we deal with infant ALLs, the T-cell ALL. So there have been a lot of advances being made, but one of the advances which I'm going to talking to you today is immunotherapy in pediatric ALL. And as we all know, immunotherapy uses the cellular or the humoral system of the body to deal with the malignancy, and that either is a monoclonal antibodies, which is conjugate or unconjugated, which we will be discussing in the next few slides, or it can be cellular therapy in the terms of adaptive T cell transfer, either with T cells or NK cells, which can be modified or unmodified. Cancer vaccines, all that hasn't got a major role in ALL. And hematopoietic stem cell transplantation, of course, is also an immunotherapy, a cellular form of immunotherapy which can be used. Now, this is a very important, I think a nice cartoon which kind of shows us how the progress over the period has been made in the field of immunotherapy. Starting from autologous bone marrow transplantation to allogeneic bone marrow transplantation. There has been some data on tumor infiltrating lymphocytes, donor lymphocyte infusions to deal with the post-transplant, especially post-transplant disease and relapse. And then this era of monoclonal antibodies, which was kind of started with rituximab, and then many more others which followed them. Then the era of BiTE antibodies, Immunotherapy being the typical example, and more recently the CARTI therapies. Now, what has been the paradigm shift in oncology has been these targeted treatments, where we either target the tumor, either target the host, or we target both tumor as well as the host. And these BiTEs and the CAR-Ts are kind of the best examples of where you target both the tumor as well as the host to have the anti-tumor activity. Now, going to the first component of the immunotherapy or the target therapy, that's monoclonal antibodies. Ideally, to qualify for a good target for a monoclonal antibodies, the antigen should be highly expressed in the tumor cells. They should be no expression or limited expression of the non-tumor cells, because you don't want to wipe off the non-tumor cells. They should not be shed or excreted. They should play a role in the cell survival, and of course not frequently mutated. And I will explain this later on how this is very important. And the typical example was CD20 and rituximab being the monoclonal antibody. So this is a cartoon which shows us what are the B cell surface antigens, or the surface targets which can be targeted. 19, 20, 22, and the CD52 are the typical ones where the targeted treatment has been tried with monoclonal antibodies. So how do these antibodies act? There are various modes of action, the predominant being the antibody-mediated cellular toxicity. It can be complement-mediated cytotoxicity, and some of the times these monoclonal antibodies do have a direct interactions leading to apoptosis and the proliferation arrest. And this is a cartoon exactly showing what it is in the previous slide, how these antibodies against these cancer cells can act. Now, these antibodies can be enhanced, can be more effective by various mechanisms. One of the mechanisms is humanization, because when you humanize antibodies, you have decreased antigenicity, and the typical example of that is rituximab and Immunotherapy. Now, we can also conjugate these antibodies to toxins or radioisotopes or chemotherapies, and we can also have bispecific antibodies, and these are the mechanisms where these antibodies can be made more potent and probably more specific and long-lasting. Now, the examples of unconjugated antibodies are these here, which I'm not going to read out. Pediatrics, Antuzumab, rituximab being the typical ones, but the conjugated ones are the ones which interest us, and I'm going to discuss in a little bit detail. And the typical example of conjugate antibodies is Antuzumab, ozogomycin, which anti-CD22 is linked to calciamycin, which is a toxin, and we'll see how it helps. There are other conjugate antibodies also in the pipeline are being studied by the various groups all across the world. So Antuzumab, we know that CD22 is expressed on more than 90% of ALLs, and this Antuzumab is an anti-CD22 humanized antibody, conjugate calciamycin. And what happens is that when this binds to the surface of the cells, internalization of the antibody happens. When lysosomal degradation happens, the calciamycin is released from the antibodies, and that calciamycin activation leads to DNA break and the apoptosis and the cell death, and that's how Immunotherapy acts when it's given to the patients. Now, the second targeted antibody treatment which we're going to be discussing today is the BiTE antibodies, or the bispecific antibodies, and the typical example of that being Immunotherapy, which has got two binding sites. On the one end of the site, it's got a binding site for CD19, which is kind of universally expressed in ALL cells. More than 90% of the patients will have this. And on the other hand, it has got a CD3 binding site, and it kind of mobilizes and binds the cytotoxic T cells of the host, and that leads to the T cell activation and cell kill, and that's how it kind of generates and stimulates the host cells to lead to the anti-cancer killing of the CD19 cells expressed with ALLs. Now, what's the data? The pediatric, I'm not, for the short, for the want of time, I'm not going to discuss data in adults, which in fact is more compelling, I would say. But what's the experience with blinatumomab? So pediatric experience with blinatumomab, this was a earlier study which came from the European group. It was a phase 1, phase 2 study on relapsed and refractory ALL with a marrow blast of more than 25%. So they used blinatumomab, 5 mics per kg for 1 week, and then 5 mics per kg per day for 3 weeks post that. And to the surprise, what was seen is that almost 40% of the patients went to CR. And the patients who responded, these 40% patients who went to the CR, out of them, half of the patients had MRD negative even after just 1 cycle of blinatumomab. And these are the response curves on the right hand side. This shows us the patients who got MRD response with a 1 cycle of blinatumomab had some of these about 20-30% of the patients had a long-term cure and survival, which was quite an impressive response to these high-risk relapsed refractory cases just with monodrug blinatumomab. Now, there is more data on blinatumomab in pediatrics, especially in 3 settings. One is, there was a phase 3 study where it was used for MRD positive patients and get them into MRD negative and with good success. There has been also been, because blinatumomab is not going to be myelosuppressive. So there are now studies where it has been used in the patients where you couldn't give chemotherapy probably in a relapsed refractory setting or in MRD positive setting, which have underlying fungal or bacterial infections where chemotherapy wouldn't be possible to be given. And it's also been used as a bridge for bone marrow transplant in patients with MRD positive. We all know that outcomes of transplantation are so much dependent on the MRD status before transplantation. And if they're MRD negative, the outcomes are going to be better. So a lot of groups have used this as a bridge to transplantation. So this was a publication, although only 15 patients, but then they used blinatumomab as a bridge to transplantation in the patient who are MRD positive, and they demonstrated the patients who had transplantation after being MRD negative. These high risk patients had almost 50 to 60% long-term survival, after blinatumomab therapy. Now, what's the data on Inotuzumab? So Inotuzumab, of course, the data in adults is quite mature now, but in pediatrics, this is from the largest series by Dr. Deepa and group, where they analyzed the data on 51 odd patients where Inotuzumab was used in a compassionate program. These were all relapsed refractory ALL patients. And again, a fantastic response. 67% patients had CR, and out of these patients who were in CR, almost 70% patients were MRD negative. We have to remember Antuzumab has got a couple of important side effects to remember, transaminitis being one, and the most important being the veno-occlusive disease of the liver post HSCT. So some of these patients who underwent bone marrow transplantation after achieving remission and MRD, there was a significant risk of veno-occlusive disease post-transplant. That's something which we need to keep in mind. Okay, now changing gears and getting the second component of immunotherapy in ALL, and that is the CARTI therapy. And we all are aware of this picture, how a CARTI is delivered. We do a leukapheresis, get the T cells out. The T cells are activated and transduced. These modified T cells are expanded after that. They are released after quality checks. Patient gets some preparatory chemotherapy, and these T cells are modified T cells infused into the patient. And this is just the cartoon exactly showing the same thing. So these CAR-Ts identify the CAR antigen on the tumor's surface, which leads to the activation and cell death and tumor apoptosis. Now, what are the advantages of CAR-T therapy? One is it's a single point of time. We just give one-time treatment and that's it. It's actually independent recognition. So autologous cells most commonly used, and there's of course no risk of GVHD and persistence of these T cells will kind of deal with these cancer cells for a prolonged period of time. Now, these are some of the advantages, and just getting into the concept of this CAR-T receptor, which is probably the most important element in the CAR-T therapy. And we all know this CAR-T receptor has got extracellular and intracellular domain. The extracellular domain is the binding site, and then there's something called as hinge region, which binds the two. And then we have got in intracellular domains, which are activation domains, co-stimulatory domains, as well as CD3 beta chains, which is a signaling domain. And these are important. Why I'm saying this, because these are important. That's how we kind of determine how the CARs have evolved over a period of time. There's something called as first generation, second generation, the third generation CARs, and depending on their extracellular, intracellular domains, they kind of have classified into these first, second, and third generation CARs. If you see the first generation CAR, they were only signaling domains. There was no, co-stimulatory domains. And then, there's a introduction of this co-stimulatory domain, like CD28 being the typical example, and that's kind of became the second generation CAR. This is important because these secondaries, the persistence and the proliferation of the T cells is quite heavily dependent on these co-stimulatory and signaling domains, and that can lead to the persistence for a long time. Now, we also, these are some of the typical anti-CD19 CAR-T constructs which have been used by different groups all over the world. If you see here, MSKCC has been using predominantly, CD28. The CHOP group has been mainly using 41BB co-stimulatory domain. So this is important to understand when we read at the data and the long-term outcomes of these patients. It's important to understand what kind of CAR and what generation of CAR, what co-stimulatory molecules and signaling molecules were used in those CAR constructs. Now, but whatever CAR constructs have been used, this is basically just a summary of the response rates, and as we see, overall the response rates have been pretty good, and the response rate in these patients who have refractory relapse disease have been in the tune of 80 to 90 odd percent. Once this CAR therapy has been delivered, and there have been various vectors, gene vectors, viral vectors being used in different studies. Some groups, lentiviral be the most common one, but there are other vectors like retroviruses which have been used by different groups as the viral vectors. Now, Chimera, which is their CD19 CAR-T from Novartis, and this is, as we know, the first CAR for pediatric ALL, which was approved in 2017. This is approved for the patients for less than 25 years of age who have got pre-B-ALL, which is refractory or in second or later relapse. And this approval was kind of after this landmark Ileana trial, which had quite significant good responses, and I'll discuss this a little bit later on again. Now, how this CAR-T manufactured? There are two ways of doing it. It can be done automatically on automated platforms. Prodigy, Miltenyi Prodigy being one of the typical examples where it can be done, or it can be also done in the GMP labs, which is more of a semi-automated or a manual way it can be done. And depending on what technique you have used, the facilities, the infrastructure, as well as the time it takes for manufacture the CAR will be kind of dependent on that. Now, what's important before giving the CAR-T therapy is lymphodepletion. So it's very important that before these patients get CAR-T therapy, that they get lymphodepletion. And the idea of this lymphodepletion is to provide a favorable environment for these CAR-T cells to expand and survival in vitro. Probably also helps in some disease control. It helps probably in eliminating some tumor suppressor T cells, and also probably helps in some amount of immune suppression in the host, so that these T cells can proliferate and do their job. Now, this is the typical example of a fludarabine cyclophosphamide based lymphodepletion and versus no lymphodepletion. And if you see the patients who got cyclophosphamide fludarabine lymphodepletion, the proliferation of the CAR-T and the peak, the T cell proliferation was quite higher in comparing the two groups. Various lymphodepletion regimens are being used. Etoposide, cyclophosphamide, only cyclophosphamide, fludarabine, cyclophosphamide. Out of these, cyclophosphamide fludarabine is probably the most commonly used and recommended regimen for using lymphodepletion. Now, nothing is without toxicities. CAR-Ts also come with significant toxicities. Infusional toxicity is not a great problem with CAR-T because they're autologous cells. But tumor lysis can happen especially if there's a massive disease burden. But the other three are kind of important toxicities which we need to remember. Cytokine release syndrome, very well studied and a very important significant side effect, and sometimes patients will land in ICU because of this. Immune-mediated neurotoxicity, which is the ICANS, and again an important side effect with the CAR-T therapy, and cytopenias, which may be just a prolonged neutropenia or sometimes cytopenia due to macrophage activation or HLH. B-cell aplasia, which can lead to hypoglobulinemia and lifelong depends on IVIG, and I think that's very important in our setting also when we are thinking of using CAR-T for our patients. This I'll skip. This is exactly the same what we discussed in the previous slides. What are the challenges with CAR-T therapy? Now, what is the pediatric data on CAR-T? And we are all aware of the story of Emily, who got the CAR-T therapy first time and was published in NEJM by the Carl June group and Stefan a group in 2013. 2 patients were reported, and both had response to CAR-T therapies, and that led to the bigger study from the same group. 30 odd patients, 90% went into CR. And these are the curves of the patients, of these 30 odd patients. The probability of 6 months overall survival and event-free survival was in the tune of 60 to 70 odd percent. So this was first proof of principle that in pediatric ALL, just with CAR-T therapy you can achieve sustained responses and probably long-term cures. Now, this is the Ileana trial which got the camera FDA approval. It was about 70 odd pediatric and young adult patients. 80% patients achieved CR. And what was very important that at 6 months and 12 months, still 50 odd percent patients were still in CR and just with the CAR-T therapy. And these are the survival and the event-free survival curves of these patients on this trial. Now, there's been a plethora of studies. I don't have the time to get into all of these. So many studies which have been done by various groups. What has come significantly come in all these studies is that the response rates have ranged. Initial response rates have been in the tune of 80 to 90%, and by almost 1 year post-treatment, almost 50-60% of patients are still in CR and disease control. Now, what is with the problem? So, nothing comes without a problem, and there are issues with the CAR-T therapy also. Now, there are resistance which can happen with CAR-T, and one of the important mechanisms of resistance is lack of persistence of CAR-T cells. So, you may lose these CAR-T cells after a particular point of time, and that's why I was alluding to the second generation, third generation CARs, where the proliferation as well as the persistence of the CAR-T is more in the later generation CAR constructs. And very importantly, antigenic loss. So you're making a CD19 CAR, the cells become smarter, they lose the CD19, and your cells will be no longer effective against these leukemia cells because they have lost the antigen where the CAR-T would have otherwise been helpful. Now, the other discussion or other controversy which we still have not been able to answer is that will CAR-T therapy be itself enough in pediatric ALL, or we need it as a bridge to allogeneic transplantation? So the debate is still, I think, open, because I think we have come a full circle. The initial data suggested that 50-60% of the patients can be cured, and the data was usually for a year or so post-CAR. But then I think in the recent publications, which are the follow-up publications, it seems that the responses to the persistence of response doesn't seem to be holding too much. It usually by around 2 years, the response rates are about in the range of 40 odd percent. So hence, there's still, I think, a jury is still out there that whether we can use it as a bridge to allogeneic transplantation and do transplant all the patients. But there's also a group of people who feel that we should identify the patients who we think are going to have a high risk of relapse post-CAR-T. For example, the patients where T cells proliferation, CAR-T cells are reducing in number, or the patients who we see there is going to be antigenic loss. I think these are probably the patients where we can use bone marrow transplant as a consolidation option. There are other studies which are looking at different aspects. There's these famous Zuma trials, and also a trial on CD22 CAR where you're using a different target, not CD19 target. And these also are showing quite good response rates as the typical CD19 CARs. Now, what is being studied now? What is investigational? What is the current I would say thought process in the CARTI with pediatric ALL, or for that matter any ALL patients, is that bispecific CAR. So to avoid this problem of antigenic escape, can we target two antigens together? 1922 is the typical combination which is being tried, and also allogenic CARs, or what we call as the third-party CARs, where we're not using the patient's own CARs but somebody else's CARs. And again, there are some studies underway, and we should wait for the mature results of these studies to come.
Oh,
now,
sorry, Dr. Bhat.
I'm going to close with the last slide. Is that okay, or should I stop?
Yes, please, Vikrant. Thank you.
Okay, so a point on frontline therapies. So can you use frontline therapies? There have been studies in adults where blinatumomab, Antuzumab has been used with mini CVADs and even better than conventional chemotherapy. And we have some data on dasatinib and blinatumomab with Ph positive ALLs. And same thing has been explored in pediatric patients as well, where COG, the BFM, and the St. Jude's, all of them are trying, randomization of blinatumomab with chemotherapy, either in standard risk ALLs or in intermediate high risk ALLs. And importantly, St. Jude's is trying to introduce blinatumomab if the post-induction is MRD is 0.1 to 1, and CARTI therapy if the MRD is more than 1%. So we should wait for these frontline therapies to mature. And this is the last slide I have, and this is, I think, the crux of what we're discussing today. And we have seen this paper recently where they have used in adults with Ph positive ALL only dasatinib and blinatumomab in their induction, and seen tremendous results just with these two targeted agents without chemotherapy. And there was an excellent editorial being written on the paper, again published in NEJM. So I think the future holds that we may have a time when we will treat these pediatric ALL patients without any chemotherapy, probably with only targeted therapy. So to summarize, we still have got high risk patients, a small group of patients where we need to have alternative treatment modalities, and immunotherapy is emerging in a big way. Monoclonal antibodies like blinatumomab and inotuzumab have promise, especially in MRD positive disease, and CAR-T therapy is evolving and has brought a paradigm shift in the way we manage these patients. So thank you very much for your kind attention, and we get any questions if we have. Thank you very much.
Thank you so much, Sunil. That was a great talk. It was very concise. It was brilliant. I think I don't know if there are any questions so far. Nothing yet. But can I start with a couple of questions, Sunil? I just wanted to know, what are the curative options for relapsed or refractory T-cell ALL patients? And the second question was, we know that translating CAR T-cell therapy for T-ALL has not been successful so far, but are there any updates about evolving CAR T therapy for T-cell ALL, and any current updates on CAR T-cell therapy availability in India? Thank you.
Okay, so I think there were two questions. One was on T-ALL, and the second was the current updates in India. So on the T-ALL, I know there are some students who are logged in also. So it's very important, as I said earlier, to have a target which is not expressed by the normal cells in the body. And the T cells, if you target a T cell antigen, which for example CD3 or CD5 or whatever, CD7, you're going to be wiping out the T cells of the patient completely. So you're going to convert that patient into a severe combined immunodeficiency, a SCID patient, and the patient will maybe not die of leukemia but of immunodeficiency as a result of the CAR-T. So that has been an important challenge in addressing the T cell ALL with the CAR-T. Now, what can be done? I think I remember there's a couple of groups who are studying this as I mentioned earlier, just CAR-T as a what you call as a bridge. So you deliver T cell CAR-T therapy, you get the leukemia under remission, and then transplant them to give them immune recovery with allogenic bone marrow transplantation. So that's something I think we and I'm also not sure. I mean, I've not had the I don't have the specifics, but I think I'm also sure that they're trying to try to target a marker on the T cells, which probably is not going to be expressed by the normal T cells. So that was the first one. The second one is update in India. So I think there are various groups working in India to have the CARTI program is growing, and I think we have heard Gaurav, Dr. Gaurav Narula a few times from their efforts from Tata. I'm also aware some efforts from Tata Calcutta. Nihar can probably throw some more light. And we also at our center have been working on it. I think it's too premature to say, but we probably should be ready by the next year, early March, April, with our CARTI kind of trials. So that's, I think, the update. I feel that in the next 1 year or so, there should be 1 or 2 trials taking off from India as well.
Thanks, Sunil. I think because for the time limits, I'll just make a couple of comments. Very comprehensive topic. It's very difficult to make it so precise and concise within that short span of time. It's definitely an exciting time because we have come to the point where we think that the benefits of giving more and more chemotherapy and not having enough, or rather bypassing the toxicity is becoming difficult. So we have to look at different avenues to do this. And immunotherapy obviously is the in thing for the time being. My issues with this particular modality, it's still early, it's still shaping up. But whenever we are targeting therapies, immunotherapy is not new because it had been tried in 1960s as well, but in a completely different way. But that we are targeting different antigens. So whether it's a CD19, 22, so whether it's CARTI or there's a Blina or Antuzumab, it just feels that we are cutting the head off one of the heads of the Hydra or the Ravan, and then some other head pops up. So at some point, we might have to have another sort of therapy which would possibly be targeting something which is more defining for that particular disease, because the disease, ALL disease, even though we call it homogeneous, it's a very heterogeneous disease. So anyway, that's that comment. Just one question for you. In terms of the cost implications, particularly that has bugged us all, people who are treating patients in a resource-limited setting, where do you see us in 5 years' time trying to implement all this immunotherapy in India?
So, it's a very complex question, Nihar. I think you know the answer to this already. And, unless and until we have our own CAR constructs, we have our own, I would say, manufacturing processes in place, the cost is going to be quite a big deterrent. Even then, it's going to be a deterrent. But I think in the current scenario, if we, for example, want to use camera, and they have shown some interest, where we can get ourselves manufactured at Novartis facility and get back and but that kind of costing is quite prohibitive. $750,000 to get a CAR-T therapy done is quite prohibitive for us. I feel it's going to be expensive treatment, whatever we do, at least in the near future, even with our own facilities and our own ways of manufacturing it. But I personally feel if you are able to deliver it in the 15-20 lakh range, that is equivalent to cost of a HSCT. It should still be in that, I would say, a comfort zone, or probably in a range where we can at least offer some of the patients this treatment. But the current costs are quite prohibitive, and this is also one of the things which we at our center, in our CARTI program, which is kind of taking some shape, we are very aware of, and we think that if it's in this range, then only it's going to be of any help to our patients. How we do that is, I think, is a big Pandora's box.
Thanks, Sunil. I think we are coming to the end of the session. I'll let Vasudha take over the session.
Thank you so much, Dr. Sunil, for that really concise talk. Like Dr. Nihar said, I think really exciting times ahead. Hope that whatever targeted therapies that can be offered to our children in India also sometime soon. Thank you so much for the talk. Thank you, Dr. Nihar and Dr. Parneet, for your valuable time to chair the session.